that on my end. Okay. Right, do you want me to start?
Yes, please. Yeah.
Okay. Good morning. Well, it's not good morning. Good afternoon, everyone, and welcome to our event today, sponsored by the IBPSA England. And we are going to talk today about environments of care facilities. I am Dr. Neveen Hamza, a reader in architecture, energy, and well-being from the School of Architecture, Planning and Landscape from Newcastle University, UK, not Australia. So, I would like to welcome Anna Margoviani from UCL and Rajat Gupta from Oxford Brookes. Hello, Rajat. Thank you for joining us. And I think I will start very quickly. The aim is to present each presentation in about 20 to 25 minutes, just to give you all an opportunity for a question and answer session and a good chat afterwards. Okay. So, it's frozen. Dear me. Okay, now it's working. So my presentation today will be about environments for reducing agitation in people with dementia. And I think it's appropriate to start just explaining that this is a project that's funded by the Wellcome Trust. And the team is composed of, it's an interdisciplinary team composed of architects, including myself and my research associates, and consultant psychiatric medics, headed by Dr. Jonathan Richardson and Dr. Keith Reed, and David Anderson, all from the Cumbria, Northumberland, Tyne and Wear NHS Trust. They're all very long titles, and apologies for that. And what we're trying to achieve is really look at possibilities of understanding how the environments in hospital wards that are specialized in dementia care, and how these wards have an impact on agitation behavior, with a remit of decreasing psychotropic medication, because there is now solid evidence that psychotropic medication actually leads to deteriorating dementia quicker in patients. So there is a need really to reduce that in every possible way. And when we hopefully arrive at the end of this project, we will be able to quantify guidelines that will also be used for estates to construct new buildings, but also that would be used in teaching a young generation of architects how to design for people with dementia. Dementia is unfortunately a rising disease, and it has been recently listed as a terminal disease. So today, it's in every 3 seconds, someone in the world develops dementia. Not everybody is diagnosed. Unfortunately, in most other countries, non-European countries, and even in some European countries, it's still very much stigmatized as a disease. So even if people are diagnosed, sometimes this is not made publicly. It's in the UK, at the moment, there are about 850,000 people, and the projections are this will increase to 2 million by 2050. And unfortunately, it doesn't just affect people who are over 65, it also affects people who are under this age. And there is at the moment 42,000 people in the UK who are diagnosed with dementia. The costs of dementia are very high because it's a one-to-one care model, and the estimated cost at the moment is 26.2 billion annually. This is a very high bill. The equivalent of fueling every country in the UK. At the same time, challenges arise because there is a lack of purpose-built care facilities, and because there is a lack of purpose-built care facilities, we also understand quite little about the environments required. and hence our research today. And we are trying to generalize these findings to other care contexts. So understanding thermal comfort and daylight comfort, acoustic comfort is in this case a live experiment. And we do understand that it is confounded by non-controlled variables that relate to the patient's health. So when we talk about dementia, dementia is not one disease. It's actually, there are several subdivisions, but the four main ones are, the known ones are Alzheimer's, but there are atypical Alzheimer's also known, like vascular dementia, frontotemporal dementia. This affects the front part of the brain, and this is quite damaging to sensation of thermal conditions around the body. And there is dementia with Lewy bodies as well. What you can see above here is CT scans of how the brain itself starts to shrink over time. And unfortunately, this also affects how the body remembers to control its own functioning. At the moment, our research is very much oriented towards quantification, because there are a number of a growing body of research and a number of guidelines that advocates the need to provide suitable environmental conditions. This is linked to better recovery time, reducing trips and falls, and eventually a reduction of one-to-one time spent in taking care of people with dementia or a person with dementia. So you would find a lot in literature about the need to provide suitable levels of daylight, the need to provide appropriate thermal conditions. What does that actually mean? There is very little understanding of what that means. And sometimes it even goes to saying things like make small-scale improvements, like purchasing colored crockery. So really that doesn't help us as architects in building appropriate care facilities. And the recent research has been advocating that thermal conditions in these facilities is actually a much narrower band than what we find in a normal, healthy, abled body. So our research is really looking at buildings that are sustainable, and at the same time compensate for cognitive decline, acknowledging that there is a lack of agency interacting with environmental control, and that thermal, visual, and acoustic discomfort cannot be communicated by the person with dementia, but will be inferred by interpreted behaviors that their carers just observe. At the moment, no thermal visual comfort solid guidelines that would help us. And although literature suggests a narrower comfort range between 18 and 27, the ends of this range are perceived to be too cold or too hot. And what really complicates our research a little bit is that dementia is a very individual type of disease, and it exhibits itself differently from one person to another. And the history of that person, their habits and culture also has an implication. So what you can see here in the image on your right is, this is obviously a summer day in the care home, but the daughter and the mother, the difference between their clothing level, and this is because the mother would have been used to presenting herself in a certain way that doesn't necessarily commiserate with the being in summer or winter. So our methodology really is looking at a controlled life experiment. So we're looking at an award-winning assessment dementia wards in, it's called Roker and Mowbray wards in the Monk Wearmouth Hospital. There are 24 beds in this hospital, and it's 2 separate male and female wards, so they're not mixed. And what we're trying to do is a comparative observational study that is supported by monitored data over a period of 2 years. And this is correlated to an anonymized database of agitation incidents that the medical side of this team is looking at. So we measure the environmental conditions. We will be doing the building simulation to reach a more sustainable yet comfortable architectural configurations, while they are looking at the medical side of this. So we're hoping that when we finish this, we arrive at quantified ranges that could be generalized to nursing, residential homes, and care homes. So we all agree that you can't improve what can't be measured. So we have to understand a little bit about the conditions of the medical conditions of an aging population, and particularly an aging population with dementia. And you can see here the most three common vision influences that happen by aging, and you can see the cataract and how this really affects the person's vision, AMDs, and glaucoma as well. These are really important when choosing colors. It has an implication on colors and how the color rendering and sharpness is perceived, which in turn will have an implication on how we design daylight and the provision of that and its mixture with daylight provision through windows. So the rule of thumb really is, we all know the color charts, that when we choose colors, that we skip one in the middle to provide contrast between floors and furniture and floors and walls. But interestingly, as I always tell my students, designing for dementia is designing with contrasts in everything. So when we design the floor, we can't really design a floor that has contrasts, and we can't design floors that receive a lot of sharp contrast of daylight from windows, because all of that contrast will be perceived as holes in the ground, and this will affect how people start walking and can lead to trips and falls. So as you can see here, the uniformity of lighting is crucial. While we really aim to provide the largest possible window areas, you're still trying to avoid glare at all costs and distribute the electrical lighting sources from different orientations, so it doesn't create that very sharp shade and shadow. Also, there are many restrictions when we're designing care rooms. Basically, there are 5 axes of vision. So we design from the pillow, as we call it. So a person who is sleeping in bed needs to have direct access to the toilet itself, not the toilet space, the toilet pan itself. And they have to have access to a view outside, and also they have to have access to the door so they don't feel trapped, and the television and their visitors, because so you can see here there is also a major impact that daylight simulation needs to play. So we test all the designs, the rooms, so there isn't this kind of effect, that very sharp contrast between one area and another. And there are several ways to deal with this. So you could introduce furniture when it becomes really that sharp. We also acknowledge that environmental psychology plays a major role here. So there needs to be a view to a green space, not just a view from a window, but to a green space, because this is therapeutic. And access to outdoor gardens and walking path. Also, one of the difficult things, the challenging things to deal with when you're designing for people with dementia is that they have the wandering syndrome. Although they're old and frail, they don't really tend to sit in their place for a long time. So they wander most of the time when they're awake. And the other constraints on design is that it has to be a personalized design. because people have a long-term memory, not a short-term memory. And to reduce the effects of dementia on patients, we also need to consider providing spaces for intergenerational activities. And this means that children, grandchildren, and their own family can come, and they can just even do little activities like playing cards, playing games. This has a recognized effect on reducing the impact of dementia. Monitoring the environment in a setting like that has many challenges. So as you can see here, there is regulation on what type of monitoring equipment we can use. So there is a regulation on the length of cables, because they have to be very short to prevent the risk of ligature. So nobody can use them to smother themselves or something like that. Also, although all of these equipment, this one here was for monitoring air qualities. These are the normal hobos for monitoring air temperature, occupancy, daylight levels, and this is for sound levels. All of them need some electrical input at some point, or the best scenario is to connect them to the hospital Wi-Fi, so we don't need to go there to download the data. Unfortunately, this wasn't possible for several security reasons, so we now have to go every week to download the data, which is not really ideal. Building urban simulation starts to play another major role in this, because we are using this particular building that we're looking at is heavily monitored by its own sensors that lead to a BMS system. And what we're trying to do is to use our monitored data, their monitored data, to calibrate the data. But what we're also recognizing is, because it's a facility for elder care, that the temperature range, the air temperature range in which the facilities are kept at, tends to be higher than those that would be recommended for an office space. So as you can see here, if this was an office space, we would be looking at this range, and a little bit higher if adaptive comfort limits are used. But because it's a care facility, then really we're looking at temperatures between 21 and 24 that are allowed to go a little bit higher. So what we're trying to do is use a number of simulation tools that would lead to understanding how to design the rooms better to reduce energy demand, but at the same time respond to appropriate conditions for those people with dementia, and use computational fluid dynamics or urban performance simulation in this case to mask the building. And the most important thing for us here is designing entrances where there isn't a very high wind velocity, and providing outdoor space that would be conducive for those patients to go outside and be active during the day. So you can see here, this is the range of recommended by ASHRAE standards for thermal conditions in care facilities. Now, we as architects were very much interested in the interpretation of the program of architecture, and unfortunately, the design of dementia wards has evolved in its history from 3 generations of jail design. And the most prominent theory behind these designs was the observation, that you minimize the number of people who observe people walking in and out of spaces, and in the case of dementia, just to reduce trips and falls. If anybody needs immediate care, then they could be provided with that. Now, as you will see in the next slides, how this has become quite inappropriate. Although in many other countries around the world, it's still the architecture theory that underpins the design of dementia care wards. Unfortunately, due to economic situations around the world. The wards are not individual rooms. They are usually occupied by more than one person, between 4 and 9 people. The corridor itself is very much used as a wandering space, and sometimes, because it's a double-sided ward, as you can see, there's only one source of light at the end, and you can see the kind of contrast of on the floor that this kind of arrangement creates, and how the people with dementia are really trying to avoid going to this place, perceiving it as a hole in the ground. Corridor spaces are very important, as I said, for wandering, but they are also sometimes used as resting space. And we are now in the NHS trying very, very much to avoid this kind of scenario. Although, I must add, it's probably more energy efficient than the other scenarios that we're looking at. So as you can see here, the double-sided corridor is always used as a wandering path that leads to one lounge or the other. And this here shows you how the one-to-one care happens in the corridor and the wandering behaviors. So building simulation helps us a lot to avoid this tunnel effect that is created by double-sided corridors. And it also helps us to look at possible mitigation measures, whether by artificial lighting, sun pipes, or other mechanisms to provide a more uniform space. The history of designing for people with dementia developed a little bit, and of course in the up to the late 1800s, unfortunately, it was considered that anybody with dementia is bewitched, and they would be beaten, they would be kept in hospital cellars and half flooded with water. So it was terrible. So really, when Lawton and his colleagues came over in the 1970s, they started suggesting that for observational purposes, that the nursing care would be included in the living space and the beds on both sides. Of course, this also creates a very dark situation, and maximum you could provide daylight from the ceiling. The current trend, and this is the wards that we are currently monitoring, you can see here, they're all designed going back to the cloister effect, but the cloister effect that was in cathedrals for the nuns and for the monks is now translated into an internal space, and these are the bedrooms and the bathrooms, the specialized bathrooms. And here you can find the living rooms, the dining room, and quiet rooms. Now, the quiet room is a very important component in the design, because one of the methods of decreasing agitation in patients is really to distract them first, to try and say, okay, let's move to another room. And maybe that by doing that, you introduce them to a quieter, more intimate space. So the agitation as well reduces. The placement of these rooms, crucial rooms in the plan, has to be studied very thoroughly by building performance simulation, because you want to provide the appropriate thermal conditions that we will talk about in a minute. So our research looked at a comparative study first to understand where do the maximum incidence of agitation happened. We compared a purpose-built and a non-purpose-built or a reappropriated ward. And the general findings were that corridors, communal spaces were the maximum spaces where agitation incidents happened. There are incidents that happens in bedrooms, but these are usually because of being agitated, that somebody is so close and trying to undertake personal care on the person. And we found that this is more with males than females. So really we stopped looking at bedrooms because it was a very special incidence and there weren't much agitation incidents in them. Very quickly, the findings that aren't published yet, so you are the first people to look at them. At the moment, we did not find any particular pattern of incidents of agitation that are related to the time of day. So they happen throughout. And we also looked at over a year. We had data for over a year so far, and we looked at the prominence of certain thermal air conditions in the room. And although at 22 was the predominant air temperature, we found here that the risk of incidents increased as the temperature fell out of the 22.5 kind of air temperatures. So what you see here is a logarithmic scale. These points here are not the incidents. These are a number of incidents happening. And as you can see, this is the female ward. And as the temperatures increased, there is a possibility of 60% that agitation will start happening. This has also been compared to another study that took place in Australia. And although the incidence is presented here in a different way, these are number of incidents. You can see that the number of incidents as well started to increase above 23.5. Taking into consideration that the climatic context, the habits and culture of people will have an impact on understanding at what temperature range do these agitation incidents tend to increase, because they can be acclimatized to different things. So we understand now that the buildings needs to provide environments that compensate for sensory, cognitive, and physical impairments. And at the same time, these environments need to be engaging, maximize dignity and independence, and they're welcoming to everybody, yet there are spaces for private areas, and we need to control overstimulation by the environment as a whole, the physical environment, the furnishing, the colors, but also the thermal, visual, and acoustic environment. I don't want to take too much time, and I'll try to wrap up very quickly. This is just an example of how we took the understandings and lessons from this research into the design studio in the architecture school. And this is a live project, and we were working on this area that was scheduled for demolishing all the buildings on it. This is an NHS property, and currently it's also co-owned by the university, which was good for us to give us some more information of the background. And this will show you how urban performance simulation is used by the students. So this is the volume of what is needed as an interpretation of the program, and then it starts taking out parts of this volume to provide the indoor courtyards and look at orienting the bedrooms so they can receive maximum sunlight for therapeutic reasons. And then how the final massing starts to work for the wandering path around certain corridors, and then at the same time how this how reducing the air velocity in the courtyard to improve and increase the use of outdoor spaces can be achieved. At the end, we all know that a good building design will reduce energy demand quite considerably. And it's really, we believe, in the hands of an architect to reduce 55% at least of the energy demand in a building by appropriately designing the building for its users. And at the same time, in conclusion, I just want to say that management of late-stage dementia should ensure a person's level of comfort and well-being versus aggressive medical interventions causing pain and discomfort. And this has been one of the major recommendations that came out of the World Alzheimer's report that was recently published. Building performance and urban performance simulation can be used as a proxy to design buildings that compensate for cognitive decline and lack of agency in controlling environments. Caring for a person with dementia is highly dependent on a very good care scheme. And we have to acknowledge that this will entail using more energy. We just need to find ways to provide more energy, but yet at the same time, not make it so excessively in need that it starts affecting well-being. Good architecture, and we hope that is tested by building and urban performance simulation, can reduce energy demand. And most importantly, that we really need to educate a new genre of architects, a new generation that knows how to use these tools as design tools, not as confirmation tools that they meet certain guidelines or numerical values. What I'd like to remind us all at the end is people with dementia are still with us. And those two movies are really spectacular in making us understand what a person with dementia feels. And they have a past, present, and future, and we need to provide for that. Thank you for your time, and please share your thoughts. And I will leave you with my email just in case further discussions you would like to undertake after we finish the event. Okay, thank you very much. Now we'll stop sharing. Okay, I think it's over to you, Anna and Rajat.
Yes, I think I'm going to start first, and then Anna, you can.
Yes, thank you, Rajat.
We'll do a double act. Okay. Can you all see my screen? I'm just going to make a slideshow of it.
Yes, now we can.
Okay, good. So I'm just going to put this away.
Yes, we can see it.
Okay, good. So thank you, Neveen, for that presentation. That was really interesting and impressive. So what Anna and I are going to do is share some insights from an ongoing project or body of work that we've done over the last kind of 5 years, where we focus specifically on UK care homes and examine the risk of summertime overheating, the bit that is not talked about that much. And we've used a range of methods for it. They're pretty socio-technical, similar to, say, some extent what Neveen was talking about. And we've tried to kind of go on to now a nationwide study as well. So I'll talk about our monitoring side of it, and then Anna will talk about modeling and how monitoring has been brought together in that sphere. So just to start off, to give some context, we know this is becoming very evident. We are living in an aging society, obviously, and we also know the climate is changing and it's getting hotter and hotter. We've witnessed the 40 degrees Celsius in UK this summer. We also know that heat-related mortality during heat waves is highest among occupants of residential and nursing homes. And despite the presence of care staff, who could kind of act to protect these residents. And that also has been evident in the recent heat wave we had in the summer 22, where UK Health Security Agency are saying there have been about 3,200 excess summer deaths, and largely they are amongst over 65. So this is a very kind of pertinent and kind of a global issue now. This was recognized widely, both in the climate change risk assessment of 2017 and 2022 by the UK government. And it was explicitly said in that risk assessment that summertime overheating in care settings is a key risk and research priority for the health and social care system. Unfortunately, the evidence base has been quite limited, and that's how we kind of have come in to this. The other issue we have is that in the UK, awareness of thermal risks and vulnerabilities, especially for older age, tends to be focused more on cold than on heat, because there's that perception that old feel the cold, which is true to some extent, but also, when it gets very hot and thresholds get crossed, there are other kind of, issues, medical issues that can be triggered. Also, we found that settings for the elderly, such as care homes, they have been designed, built, and operated, again, with the aim of keeping residents comfortably warm. So we've often seen, for example, pipe work in care homes with the hot water during the summer as well, leading to unwanted summer gains because the heating gets left on. And that all kind of came together and kicked off this kind of body of work that we started in 2018. This was funded through the Natural Environment Research Council as part of their climate adaptation program. And we started this project by looking at a pilot study of 5 care homes in London. Prior to that, I had done a study of a Joseph Rowntree Foundation looking at care homes and extra care homes as well. So there was some kind of, a track record emerging. In the pilot study that we did, our main objective was to look at a range of care homes, some modern, some very old, and some in between, and try and see whether we could do some feasibility work by developing new methods, knowledge, and insights to help care provision become resilient, and also lead to a follow-on project to do a nationwide piece. And that's what we then started. So in 2020, once the pilot study finished, NERC was very kind to fund our nationwide study, which is the study where we are looking at across the country what are these heat risks in care provision at a national level. We want to enhance our understanding of individual behaviors and how that could help in tackling overheating. We also want to look at organizational capacity and governance to really see whether care provision can develop in equitable ways, pathways as well. So our aim was to kind of do a longitudinal monitoring of about between 40 and 50 care settings across the country, and by longitudinal we mean at least 2 or 3 summers, and then do more details in a subsample, and then look at the heat exposure on the health of residents, and then use sophisticated modeling methods to develop a stock model. So essentially, after the project, we would have archetypes that we could use to model whether improvements for tackling overheating now or in the future, or even for looking at energy demand. And then alongside that, we've got this very elegant kind of social science-based approach on stakeholder development and doing participatory research, where we are really engaging with stakeholders to further explore organizational capacity and structures and how that can influence adaptation measures for tackling overheating. We are going to focus on today looking at the monitoring side and the modeling side of the project. So this is the research team. So apart from Anna and myself, the project is led by Professor Mike Davis in University College London, and there are other members of the team as well. We also are working closely with London School of Hygiene and Tropical Medicine. Unfortunately, we lost Paul Wilkinson, as some of you might know, and I is now kind of leading the work from LSHTM. And then there are other researchers. Alistair Howard is working, Eleni and Iona, and other researchers as well from UCL. So it's quite a nice large team to help with this nationwide project. So we've at the moment we are working with about 45 care homes that we've kind of monitored across the country. So you can see the North, Midlands, London, and South as well. It's a good mix of urban, suburban, rural, care homes. I wouldn't underplay how challenging it was to recruit them. Some of it, I think, Neveen had mentioned as well. These are settings quite hard to work in. They still have, COVID protocols in place. It's not easy to install monitoring equipment there. Also, you can't use the Wi-Fi. There are also, issues when there are, resident turnover and other bits happening. So I think despite all that, we're very grateful that Care Quality Commission, who's also a partner in the project, really helped us in kind of getting going with recruitment, and their kind of leadership helped us in getting these 45 care homes that we have now across the country. You can see some of the kind of care homes we have. So we have quite old care homes. You can see we also have very new ones, again with different spatial configurations, some with courtyards, some don't, and then some which are converted as well. So it's a good mix that we have from a physical performance point of view, with different age bands, with different types. So there are some purpose built, others are converted, some have been extended. And we also have, for a small subset, about 25 care homes, we also have the energy performance certificates. But it gives us a good kind of sample to work with in terms of looking at whether the risk of overheating is varying across by age or type, or even by kind of energy performance. And again, some of those which have been converted have also been kind of substantially extended. In terms of there are other characteristics. Most homes offer nursing. They also can also offer residential care. 95% of care homes are in the independent private sector, which is similar to our sample as well. The average care home in England has around 20 beds. Ours is slightly more, but I think that helps us because it gives us a larger area to monitor and more kind of choice. And then CQC ratings, again, this is the Care Quality Commission, rating on a scale of 3, outstanding, good, requires improvement. And you can see that's again similar to the national kind of stock. So we monitored a combination of spaces. We monitored, offices. We monitored the communal areas, the lounges, and also bedrooms, which obviously are really important. So we've kind of done this large-scale monitoring campaign across these 45 care homes, and looking at range of spaces with different orientations, and trying to see what is coming through. We're monitoring at about 15-minute intervals. So we've done this summer as well. And we could not kind of use the Wi-Fi, so we used Bluetooth. So visits are necessary, but sometimes we don't need to kind of go into that room to download data. That kind of is avoided through the Bluetooth-based loggers. I want to get into results because I guess that's really critical. So we're looking at this summer, May to September, the non-heating season really, and you can see that those 5 kind of bars are the heat wave periods that UK Health Security Agency had declared in UK. And I'm sure you remember the July one where temperatures really shot to 40 degrees outside. But then when we look at, these are all temperatures in bedrooms inside, and you can see that consistently, temperatures are above 30. In one kind of bedroom, we even kind of monitored 45 degrees, which is obviously alarming. Most bedrooms are above 30 degrees, during the day, which is way above the threshold that UKHSA suggests, which is around 26 degrees. And what is also startling is that the most of these bedrooms stay at over 30 degrees even at night time, when you can imagine our sleeping hours, and anyways adaptation is minimum in care homes, and it becomes even absent in during the night. So it has an effect on the sleep as well. When you compare it, we chose the guide A, the static criteria, because of the limited kind of opportunity for adaptation, and where really overheating in bedrooms is defined as 1% or more of occupied hours over 26 degrees. In this case, we can see that whichever side you look at, there is ample amount of number of occupied hours above 1%, going really above 20% as well, and then also staying like that during the night time. And in fact, some of them are even exceeding 40 and 60 and even approaching 80-90%. So in short, there's the risk of kind of overheating is prevalent throughout, irrespective of building age, the type of care home, and in terms of who the provider is. So this is a serious and dominant problem across the country. We also planted relative humidity loggers, so we could look at what was the effect, because that also helps us in seeing whether it's very dry or it's very kind of moist. And again, we monitored that, and CIPSI recommended it between 40 to 60%. And we found that hourly average relative humidity was below 40% for about 27% of monitored hours, and then up to 80% of monitored hours in the first bedroom. So essentially, we were observing conditions which were quite dry, indicating that there might be some negative health consequences of this dryness, and possibly because of lack of ventilation as well. We then also did comfort surveys. Again, this is probably one of the largest study of comfort surveys across care homes in the country. We had comfort surveys both for residents and staff, and we collected over 2,000 responses. That was done over 150 visits. I'm really grateful to our team for kind of getting this level of data. And what you find is again an interesting kind of insight, is that compared to the residents, staff members are significantly feel they're more warm, hot, and they found the temperatures less tolerable, and they would have preferred to be much cooler. Now, this is quite a serious thing, that residents are not perceiving the heat, and they are thinking that it's okay, and they're feeling neutral, which means some level of external intervention is necessary so that the temperatures don't go higher than the threshold and lead to kind of medical issues. I'm going to just give summary of findings and then hand over to Anna. So just to bring it all together for monitoring, that we feel our care home sample is fairly representative of the wider care home population. We also, it's very evident that with our initial analysis of this summer, that high indoor temperatures are evident. It's much about 26 degrees, 1% of May to September. We are looking at even, 35, 40 degrees. And the low levels of humidity, again, is a concern because, that could indicate limited ventilation. That also indicates that, you can have other issues such as airborne virus spread and issues related to dryness of skin. I'm going to stop sharing here and hand over to Anna.
Great, thank you so much, Rajat. So I'll start sharing my screen. Okay. Can you please let me know if you can see it full screen now? Great, thank you so much. And I'd like to thank Neveen as well for a very interesting presentation, and also Rajat for a great overview of the Climate Care project and all the monitoring work that has been carried out. That I think is really going to result in a very unique data set of indoor thermal performance of care homes. So we have a few minutes left, and what I'd like to focus on is on a modeling study that we did in two case study care homes from the London pilot study that Rajat mentioned earlier. So this study has been presented in a paper we published last year in Energy in Buildings. So these are two very different case study care homes. The first one, PA, it's a much older building. It was constructed in the Georgian period, and then it was a manor house, I believe, and then was converted into a care home in the 1980s. So it's in a suburban location close to Heathrow, and it has a capacity of around 44 residents. The VI care home is a much more recently built care home. It's purpose-built, so it was designed to function as a care home, and it's located in northwest London in a very urban, densely built area, and it's a much larger care home with a much larger capacity. And you can see there some of their other characteristics. So in their majority, the residents are above 65, but the more recently built care home also has some younger residents, some of them suffering from conditions such as dementia or other disability, and they're both privately owned and naturally ventilated. And you can see the differences as well in the U value, so very different constructions. And just to say that the majority of the rooms in the PA care home are south-oriented, whereas in the VI one, there is more of a distribution across orientations. So those two care homes were monitored during the summer of 2019 as part of the pilot part of the Climate Care project. And then we carried out modeling using the dynamic building performance software package Energy Plus, via the Design Builder graphical user interface. This is because Energy Plus is a widely tested and validated building performance simulation program. And since a heat wave is considered to be a period with at least a 3-day moving average of external temperatures rising above 21.5 degrees, we decided to carry out analysis for a 5-day heat wave period, which for the summer of 2019 was between the 22nd and 26th of July. And then we carried out simulation for the current climate by using data from the London Weather Centre for the urban care home and Heathrow for the suburban care home. And then we also carried out simulation for a future climate change weather file, design summer year 1 for the 2080s time slice under a high emission scenario. So these weather files are provided from IBPSA, and they're based on the UK climate change projections 2009. Of course, since then we also have UK CP18 weather file, climate projections. But unfortunately, these are not yet available in a format that would be suitable for building performance simulation. So we use UKCP09. And just to mention that through the physical surveys of the case studies, technical drawings that were made available to us, we derived a series of building fabric modeling inputs, and these were supplemented by inputs that were derived from RDSUB as a function construction aids type, etc. So the first step that we completed in order to ensure modeling robustness was to compare the model temperatures for the baseline model, so the models that use the 2009 actual weather data from typical zones for each case study care home against those that were collected during the monitoring that Raja presented earlier for this heatwave period. So you can see there the comparison between monitor and model data for 3 key spaces in each one of the case studies: office, a lounge, and a bedroom. And we found that those validation checks indicate that the model data was a close enough match to the monitor data and could therefore be used for overheating prediction analysis, and also to allow us to test the effectiveness of a series of passive and active building adaptation strategies. And this is another visualization of the comparison between monitored and model data. And you can see there that both monitored and model average temperatures were very close or exceeded the 26 degrees Celsius threshold that at the time was suggested by the PHE. And the values and trends were very similar across both data sets. And broadly, there were the differences within a 2 degrees Celsius range, which we thought was acceptable. Interestingly, we found a higher deviation in the bedrooms of both care homes, and we thought that this could potentially be attributed to the uncertainty around the assumptions that we made about window operation during the nighttime. So following this comparison, we tested a number of overheating mitigation strategies, a number of interventions, and we split them up into non-structural or soft and structural hard engineering solutions. So the non-structural ones are relatively easy to implement or relatively cheap solutions, for example, behavioral adaptation, and the structural ones are the ones that tend to be more time-consuming or more technically demanding and possibly more costly as well. So this range from management of internal heat sources, different ventilation regimes, to more demanding technically interventions such as adding insulation, modifying the external surface albedo, adding shading, and of course testing active cooling options. And this is the solutions that we tested for this specific study. So S1 was the baseline. Then we had a solution where we only used air conditioning, and then air conditioning during the daytime, I should say, from 7 a.m. until 9 p.m. and but also during the nighttime for the S2 intervention. And then for S3 onwards, we had air conditioning operated during the daytime, but then combined with ventilation during the nighttime, then combined with shading, combined with reflective surfaces or modification of the albedo, and finally a combination of air conditioning during the daytime and all other passive cooling strategies. And you can see here some of those results for that 5-day heatwave period. So when we look in the future, the majority, in the 2080s high emission scenario, the majority of temperatures were between 30 and 36 degrees for the PA care home and 31 to 39 degrees in the VI care home, which means that they're well above the recommended thresholds for thermal comfort and health. And interestingly, both care homes saw a similar decrease in temperatures over the 5-day period, so similar trends being observed. I think this is one of the most interesting graphs in the study. So here we look at the relative performance of those different interventions. And I think it's evident that the combination of the hard, shall we call them, adaptations, so operation of daytime air conditioning, external shading, reflective surfaces, but also that some soft adaptations, so nighttime ventilation to purge the heat accumulated during the daytime. So that combination was found to be the most effective in reducing the need for cooling and maintaining indoor thermal comfort, both under the current climate as well as the future climate. And what I think is really interesting here also is that S3, which is the combination of active cooling and ventilation, appears to be working quite well during the current climate, but the ranking of the interventions in terms of their effectiveness changes when we look at the future climate. And I think this is because possibly we have much warmer temperatures during the nighttime, so the cooling potential of nighttime ventilation is decreased. So the most effective individual strategy there is shading. But of course, the combination of all strategies is the most effective one. So in terms of ongoing work, of course, we're continuing the building performance simulation component to develop this building stock model that Rajat was discussing earlier. We will also have monitoring data from the larger care home sample that Rajat presented. So hopefully there will be more opportunity for comparison between modeling and monitoring data. And we will be testing a much wider range of adaptation strategies and their combinations, additional climate change scenarios, and focusing on additional output variables, so not only temperature, but also relative humidity, because dry air, as Rajat mentioned, can be potentially have negative health impacts. And we already have a conference paper in a national conference to be presented next year that focuses on relative humidity. Simultaneously, we will be carrying out health impact analysis using both morbidity and mortality functions to assess the impact of the wide range of interventions on health, and also carry out economic analysis, including cost considerations on capital, running and maintenance costs of these different interventions, and also their technical feasibility assessment. So this is our website in case you would like to find out more about our project. And for the pilot project, we also produce a number of freely available publications that I think provide a nice summary of the work that has been done. And this is a list of publications if you'd like to find out more. And they include a lot of the detail that I was unable to present today. So thank you so much for listening. Hopefully, I don't know how we're doing for time. Hopefully we have 3 minutes for questions. Thank you.
I think there was a question that I took, so there isn't one left for you guys, which is, I think you can.
Yes, with regards to overheating analysis, would a care home be classed as domestic? So TM59 criteria, non-domestic TM52. Rajat, perhaps you would like to take this one because you did the overheating analysis.
Yeah, no, it's a very good question because care homes are hybrid settings. You know, they have domestic and non-domestic functionality. So we have to use a combination, I think. The second point is, remember, adaptive opportunities are limited sometimes in these settings. So it actually makes sense to have a combination of static and dynamic criteria. But yes, we possibly also need to look at overheating kind of standards for hybrid buildings, because many such buildings are there, not just care homes, where you won't have one kind of functionality.
Right. I think that's about it. I can't see how many attendees are there, so
20.
20. Okay.
Thank you all for joining. And yeah, if you have any questions about any of the work that we presented, please do get in touch by email. I think there's probably another.
That's possibly for you, I think.
Yes, I
Neveen.
think that's for you, Neveen.
Australian researchers.
Yes, I just returned from a stint as a visiting professor in Adelaide University, and it was really, really insightful because there was Hammond Care, and they kindly took me around their care homes in Australia. And it was a really good opportunity to look at the standards of thermal comfort, visual comfort, and also the physical environment provided. Yes, would be very welcome to have collaboration with Australian researchers as well. Right, I think that's it. And on that note, it's 2 o'clock on the dot. Thanks, Anna. Thanks, Rajat.
Thank you.
I hope our attendees have enjoyed the event and found it useful. And please feel welcome to email all of us at any point if you have further questions that crop up after we finish the session. And again, thanks all.
Thank you.
Thank you. Thanks, everybody.
Goodbye.
Bye.
Bye. Bye.